Hello and welcome to our webinar. And we are really, really excited that you're here today. Trauma seems to be a really big topic. And my name's Renee Barabo, and I'm the Community Outreach and Marketing Manager over at Montare Behavioral Health. And today we have our Clinical Director, Tiffany Dzioba, who will be speaking. And I'll give her a little introduction later. But right now, we're going to have Becca from Discovery Behavioral Health tell us a little bit about their operation, their business, their model.
Thank you, Renee. Hello, everyone. And it seems to be a lot of attendees from even the UK and Canada. Welcome. It's a pleasure to be here. My name is Becca Millard. I work for Discovery Behavioral Health. I'm in the Orange County area, but Discovery Behavioral Health has three different divisions. So we're able to service clients with eating disorders, mental health treatment for adolescents and adults, and substance abuse treatment. So we have multiple locations nationwide. We do have a lot of in-network contracts. So it's been such a pleasure to be able to service a lot of clients that are insurance dependent and are wanting really high quality care. And it's a pleasure to be here today co-hosting with Renewal, and especially Tiffany, to hear more about the impact of the clinical presence of trauma work. And so we're really excited that you guys are here as well. So thanks for joining us today. Thanks, Renee.
Hi, everyone. I'm Christy Kettle. I am the Director of Clinical Outreach with Renewal Health Group and Montare Behavioral Health. And yes, we are all so excited to have you here with us and really looking forward to Tiffany's presentation. She is a phenomenal clinician. Renewal Health Group, that is our parent company, and we have two divisions. We have primary substance use, where we offer the full continuum of care, and then also primary mental health, where we offer the full continuum of care. We have locations throughout Los Angeles and also in the desert. In the desert, we have primary substance use and primary mental health, PHP and IOP. And then in Los Angeles, we have primary substance use and primary mental health. The mental health program right now, we have 4 different mental health residential treatment centers. And one of our newest is in Malibu, which is where Tiffany is located. It's Montare at the Canyon. And we specialize in trauma, which Tiffany's presentation is on trauma specifically. I would say the majority of our clinicians are trained in EMDR. We can provide neurofeedback, on-site TMS, and a plethora of evidence-based modalities, as well as holistic modalities as well. And we have multiple in-network contracts. And we want to know about you guys as well. So we invite you to put all of your information into the chat. And also, if you have any questions at the end, we hopefully will be able to have some time to answer your questions. So please put your questions in the chat as well. And I'll turn it back over to Renee.
Just a little bit. Could you put your questions? There's a Q&A, which is so we can keep the chat for chatting and the Q&A for questions that Dr. Dzioba will answer during her talk, or if she doesn't, then we can ask her at the end. But she'd like you to put them into the Q&A, but also know that she just may cover them in the talk, so she'll take them all at the end. And also stay for the end, because we're going to have gift card giveaways, which is one of our fun things we like to do. But now let's get to the serious nature of trauma. The talk is called The Power of Trauma and Trauma-Informed Care, Practical Strategies in Residential Care. And Dr. Dzioba is the Clinical Director of Montare Behavioral Health in Los Angeles. And she has spent the last decade in clinical leadership roles for behavioral health care settings, creating, developing, and improving clinical treatment programs in inpatient, residential, and outpatient levels of care. Dr. Dzioba has created evidence-based clinical curriculum for mental health and addiction treatment programs and developed the spiritually integrated clinical supervision model, SIS, that she frames it as, and she has specialty in trauma treatment, and it has assisted many organizations in trauma-informed transformations. So I'm going to just, without further ado, let you take it over. And we're really, first of all, I'm really excited that you're our clinical director, and we're really excited for the interest in all the people here from all over the world. So thank you.
Well, thank you, Renee, and everybody. I'm very excited to have such a large audience for this presentation, and knowing that we have so many people from so many different parts of the world. Let me share my screen and get into the presentation. I will try to keep an eye on the Q&A as we go through, but anything that gets missed, we will make sure that we're covering when we get to the end of this. So let me start telling you first about myself and how I became interested in trauma-informed care and how I became so involved in helping organizations make this movement to becoming what we call trauma-informed. So I started in behavioral health care back in, I think 2004 is when I first started working in residential treatments. And at that time, nobody knew anything about trauma-informed care. We actually didn't know much about trauma to begin with. I would say the approaches at that point working in residential care were very focused on behavior modification, a lot of emphasis on, trying to extinguish certain behaviors, ignore behaviors, punish behaviors, with very little awareness or knowledge about trauma. Kind of fast forward to about 2010, 2011 is where the trauma-informed care movement in the facilities that I was working in really started to make a wave. People started to pay attention to the fact that trauma was underlying a lot of the behavioral issues that we saw. Instead of viewing things as, more of a conduct issue or, not wanting to be compliant, that we're recognizing a lot of the impact of trauma and the implications for that. So, I'll tell you my experience of being in a residential treatment facility who, that engaged in practices that were quite honestly very re-traumatizing in certain respects, doing a lot of seclusion, restraint, punishment, and then as we started to gain this knowledge about trauma, shifting gears in a very dramatic way. So it was about probably 2010, 2011 that I went through the first transformation with an organization of becoming trauma-informed. It took a lot of reworking everything about our system, turning everything on its head, reevaluating our policies, our rules, how we did things, how we engaged with clients, and really looking at things from a systemic organizational perspective, and then down to the actual trauma-specific treatments. So I've done this in many different settings over the years with organizations that were, kind of at different phases in terms of how far along in their progression to being truly trauma-informed they were. So I'm going to share with you some of the cornerstones of trauma-informed care, what trauma does with the brain, what it means, all of that. So let's kind of get into this. So first of all, why is this important? Why are you all here, so many of you, wanting to kind of peek in and hear me talk about this topic? So first of all, 90%, really more than 90% of clients in behavioral healthcare settings have a history of trauma. Not to blanket and say everybody, but such a significant portion that if we're not operating in a way to be sensitive to trauma and recognize it, that we're missing a very big aspect of treatments. To successfully treat clients in our setting, we have to understand how trauma affects clients on a neurological level. How does trauma show up? How does it manifest cognitively, emotionally, and behaviorally? And then we have to develop systems of care that integrate that neuroscientific understanding of trauma with our care treatment and services. So once we understand what's happening in the brain and how this affects individuals, we have to make sure that our treatment is aligned to that. Our philosophy and our belief system on why clients behave the way that they do affects how we interact with them and the interventions that we use with them. So looking at, are we interpreting client behavior or client struggles, problems as something that would be volitional? And when I say volitional, I mean that the client has choice. They know what they're doing. They have the ability to make a decision to either do it or not do it. And they are, willfully choosing to do something versus more of a brain response, a brain impairment, or you can call it a brain disease. So do our treatment environments, the facilities that we operate in, our policies, our interactions, our interventions, do they provide clients with a corrective emotional experience, or are they inadvertently, without us being aware, re-traumatizing? And this is something for us to evaluate and look at. Are we missing opportunities for healing based on our lens and our perspective on clients' behaviors and problems? So the learning objectives today. One, I want you guys to get a good overview about physiological changes in the brain and brain processes resulting from experiences of trauma. This is not going to be a super deep dive because I don't have enough time with you. However, this will give you enough of an overview for you to have a good idea about how trauma affects the brain. We're going to identify behavioral, emotional, and cognitive experiences and patterns as trauma responses. Identify specific components of trauma-informed care and residential treatment. What does that mean? I know it can be a very vague, elusive term, but what does trauma-informed care really mean? And then describe strategies and organizational changes necessary to create a trauma-informed environment and culture. So in terms of trauma in the brain, two really important resources that I highly recommend if you're going to be, learning more about trauma in the brain. Dan Siegel, The Developing Mind, he actually has, this probably his 2013 version that I have, but Dan Siegel recently updated the newest version, 2020, but so much about trauma in the brain in terms of how human connections shape neural connections comes from his work. And then Bessel van der Kolk, The Body Keeps the Score, very important in terms of how trauma shows up, how it manifests, how it affects the brain. So first of all, experience directly shapes the circuits responsible for memory, emotion, and self-awareness. So we know that our early life experiences and the types of attachments we have, the connections we make, that they are going to directly affect neural circuits, how things, develop in the brain. So parent-child attachment. Now, that attachment in the early, especially the first couple of years, but even up to, kind of early middle childhood, affects how people see the world. Physiological responses, their interpersonal patterns. So if a secure attachment would look like a parent who is attuned, who is meeting needs, keeping safety, when a child cries, they're being attended to, they know that they have security, shelter, basic needs would, develop a secure attachment. Avoidant, resistant, ambivalent, or disorganized attachments start to develop a framework and a belief that the world is not safe. I can't trust other people. I am not going to get my needs met. The world and other people are essentially not safe, and I need to protect myself. So these repeated experiences become encoded in implicit memory and as mental models or schemas that we bring into our adulthood. When it comes to traumatic events, and these can be single, it can be repeated, or oftentimes what we see very chronic trauma in terms of, someone having an experience of living in a traumatic situation over a period of time, it sears the brain with trauma memory. And that is stored in the lower, more primitive area of the brain. It is less conscious, and it involves more somatic, reactive, and reflexive responses. So what this means is that your kind of frontal lobe will get into the brain areas, but you're not thinking from more of a conscious, logical, rational area. You're reacting from more of that emotional brain. And the brain's baseline arousal level is set higher following a traumatic experience. So people are more keyed up, on alert, on guard, sort of anticipating, that there is some situation that may be dangerous. And then when trauma-based memories are triggered, people will instantaneously revert back to a more primitive brain state for protection. So we'll get into some of these different brain states. First thing we want to understand when it comes to trauma-informed care is that the most important job of the brain is to ensure our survival. And the rational cognitive part of our brain, that thinking part, the part that we're expecting people to use when it comes to making good decisions and thinking and planning and impulse control, that's only 30% of our brain. 70% of our brain that lives more in the hindbrain and the midbrain is that reptilian brain, the limbic system. It's what we call the emotional brain. And that is the heart of the nervous system. It is concerned with survival, determining danger and threat. That part of the brain is assessing all incoming data in a very global way. So rather than thinking kind of nuances, this scenario for this situation or that for that, it's really looking more globally at, is this in any way similar to something I've experienced before? And do I need to be worried or on alert because of that? So our emotional brain does a lot of jumping to conclusions, especially given a traumatic history. It initiates pre-programmed escape plans, and then we have these automatic muscular and physiological reactions. So without cognitively thinking about what's happening, we'll start to feel, certain, like our heart racing, on alert, keyed up, highly sensitive. Meanwhile, the rational conscious brain is often trying to catch up. So the emotional brain is running the show and kind of reacting without the conscious brain being able to have input. So let's talk about when there's trauma, what happens in the brainstem. So the brainstem is the part of our brain. It plays an important role in regulating primitive functions, things like breathing, your body temperature, your blood pressure, and your heart rate. So trauma, what happens with the brainstem is it causes wiring so that we have excessive reactions to threats. And it could be that, we'll get into triggers, but it could be that there is a slightly minor trigger, and the reaction is something not equal to the trigger. So it looks like somebody is going into that self-protective fight or flight mode, like going from 0 to 60 for no reason. And oftentimes when we see people have a very dramatic response to a very minor trigger, that's a good indication that there is a trauma response at play. Now, the limbic system, this is really more kind of buried deep in the middle of the brain. It's the part of the brain that involves the experience and expression of emotion. It's activated by the amygdala. So someone who has experienced trauma might have more emotionally expressive or emotionally explosive behaviors. And oftentimes we find that people have trouble modulating their emotions. Sometimes we see some cutoff from emotions where people aren't actually able to identify, be aware of, or express emotions at all. And as I mentioned, Dan Siegel talks a lot about the connection between early childhood experiences, especially early attachment, and the development of these emotion regulation systems and emotional awareness, emotional identification being heavily stunted based on these experiences. So sometimes you find that people then become dissociative, which is why we see that so common with those who have experienced trauma. So in terms of the amygdala is our smoke detector of the brain. It's the part of the brain that helps us to determine what is danger, what do I need to be aware of. The amygdala then decides what parts of the brain need to be activated and in charge based on perceptions of danger. And then we have the hippocampus, which is that computer chip of the brain. It's transferring and storing memories, but it's also all of the incoming data. It's relating it to past experiences. So what does this look like? And how do I connect this to what I've been through before? So when somebody has experienced trauma, there's a lot of misinterpretation that happens in the amygdala. So the amygdala will perceive danger from pretty neutral stimuli or a slight provocation and tell the hypothalamus and the nervous system that they have to activate for stress, activate to respond to a threat, oftentimes throwing somebody into that fight, flight, or freeze. The other thing with the hippocampus, which I think is really important, is that in studies when they've done brain scans, they actually see that there is smaller hippocampal volume based on experiences of trauma. And what this implies is that there's memory impairment due to trauma. I can't tell you how many clients I've worked with where we're getting different stories. Things don't add up. Somebody can't really tell you what happened. I've also had clients who can't remember anything during periods of time when really memory should be pretty intact. So really important to pay attention to the fact that brain changes, brain impairments could be a result of that, rather than I've heard people say, well, I think they're guarded, poor historian, hiding things like that. Then coming to the neocortex, obviously this is the most developed part of the brain. It's the most kind of higher level part of the brain, the thinking part, where we do things like planning, organizing, sensory perception, spatial reasoning. It's a part of our brain for conscious thought, language, and impulse control. So what we see, again, with brain scans, is that those who have experienced trauma, they have less cortical modulation in this area, and sometimes actually even smaller cortical areas. So in a trauma response, that emotional part of the brain, that more reptilian or animalistic or kind of primitive parts of the brain take over, and the frontal lobe and the medial prefrontal cortex aren't able to give input. Those are the parts of the brain that are responsible for balancing out things, for being able to bring in logic, reason, to second guess things, to question things. So, we're seeing that people aren't able to access that in the same way. So getting into fight, flight, and freeze. I'm sure most of you are pretty familiar with these concepts. So I'll describe sort of what happens and what it looks like behaviorally. So trauma memories can be triggered by different stimuli and situations in very, very minor ways that hold similarity to the traumatic event or even to the attachment injuries. And what this might look like, if somebody has experienced, let's say, a singular major traumatic event, like maybe we'll just pick something more neutral, like a big car crash, for example. A car crash in terms of trauma triggers, things that can trigger memories. It could be the sound of crunching metal. It could be the sound of a song that was playing when the car crash happened. It could be a certain road that you're driving down where, that's the road that crash happened, and you notice you're suddenly having like nervous system sensory reaction when in that situation. So triggers can be sights, sounds, touch, smell. For people who've experienced trauma from other individuals, physical or sexual trauma, it can be tone of voice, posture, size of the body, the way someone looks. And with attachment injuries, even limits or boundaries can be triggers that, someone has had a repeated experience of being neglected, abandoned, rejected. And so any small, any small little boundary or limit that would be close to that send somebody into that, let's say, a fight mode. So the reptilian brain and the limbic system, as I'd mentioned, they assess data globally, and they jump to conclusions. They jump to protect from minor triggers. So those, that fight, flight, freeze are pre-programmed defenses. They're already there. So what that looks like is maybe aggression, yelling, screaming, cursing, rebellion, defiance. Freeze looks like dissociation or disengagement. Flight can look like absence or avoidance. So these are the behaviors that we see that can be very challenging and actually very frustrating in treatment for us as providers. So the important thing for us is to develop our trauma lens. What this looks like is, how do we perceive what we are seeing? So individuals who are displaying dissociative or hyper-aroused behaviors, are really angry, aggressive, hostile, we can look at them and say, this is somebody with a personality disorder. This is somebody who doesn't want treatment. This is someone who's just defiant. They're aggressive, they're inattentive, they're distracted, they're attention seeking, they're manipulative. I mean, those are a lot of the ways that we tend to describe difficult clients, if we're being really honest. So, however, it could be that this is really a trauma response, that what we're seeing in terms of the behavior, the challenges, the pushback, all of that could be a trauma response. And this is kind of a question to push out to the group, is if the cognitive rational thinking part of our brain, if it's impaired or it's not able to give input or balance out the emotional brain, is this behavior truly volitional? Is someone truly in control if they're running wired off of their emotional brain that is purely primed for protection? So traumatic experiences and memories, they shape and change the brain in such a manner. It causes impairments in emotion, in cognitions and how people think, their ability to rationalize, their ability to regulate and self-soothe. Obviously, their interpersonal skills, that shows up mostly in interpersonal skills and in impulse control. So what does this mean for treatment? Well, the goal is to help people. We're all supposed to, kind of the way things are supposed to be, is that you have this balance between your frontal lobe functioning, that higher executive thinking part of the brain, and your emotional brain. You want them to be integrated, and that both have some input in how you're going to respond or react to situations. So the goal is to help rebalance that when the emotional brain is running the show and overtaking everything, then we want to get back to having a balance. You can do this a couple of ways. In a very simplistic kind of form is either top down or bottom up or both. Top down is really going from that kind of cognitive thinking part of the brain down to the lower parts of the brain. And that's really training to direct attentional focus. So mindful meditation is a very good example of this. In mindful meditation, you are training yourself to pay attention to very particular things. You can train yourself to focus on certain thoughts. You can train yourself to focus on certain sensations in your body, certain sensory experiences. So it's really about training the brain in that capacity. Bottom up is focusing on recalibrating the autonomic nervous system. And there's a lot of work that people do with the body. They access that ANS through things like breath work, movements, some type of touch. People use kind of bilateral tapping to do that. So there's a lot of ways to get into the body. Somatic experiencing work will do that as well. Really what we're aiming to do is build new neural pathways. It's the whole point of top down and bottom up, is that we're looking to reshape, retrain the brain. The wonderful thing about neuroplasticity is we have an opportunity to change things. Now, when you're getting somebody who is well into adulthood and has some pretty well-formed neural pathways, it's a challenge. It takes a lot of work, but it's not impossible. And really what we're looking to do is have corrective experiences. So I love this quote: where your attention goes, energy flows, and that's what grows. So when it comes to clients in treatment that we find very, very challenging, always thinking about how do we help them in developing new skills and new neural pathways. So some of the big cautions of treatment when we're trying to come from a very trauma-informed care approach. One is pathologizing, and this is tough because oftentimes we're dealing with very, very challenging cases, and cases in which often what we're seeing are a lot of what looks like characterological defects, personality disorders. So the language we use another caution is pejorative labeling plays a large role in, one, our view of people, our perception of them, and which then dictates kind of our level of empathy for them, and our ability, I should say, our perception of whether we're able to help them. When we have kind of defined someone and put them in a box or a category based on, this is a fixed issue, this is a fixed personality disorder, let's say, that we've suddenly taken away any ability that we believe that we have to help change them or to help them learn new strategies, learn new interpersonal skills. So, for example, oftentimes I have to even remind myself or remind my team to be careful about the overdiagnosis of borderline personality disorder, that we're really quick to jump to say, oh, that looks borderline. A way to reframe that is that when you have somebody with really significant attachment injuries and childhood wounds and trauma through childhood, that their ability to form trusting, meaningful connections with people and tolerate limits and tolerate some of the uncomfortable emotions that might come from somebody not being able to always be there or setting certain limits, then what we're seeing really is a trauma response. We're seeing interpersonal issues, explosiveness, inability to self-regulate, self-soothe. We're seeing that as a response to trauma. And so we go back to, what do we do for trauma and how do we help that? A lot of that is helping to reduce blame and shame with clients, and then avoid re-traumatizing. So when it comes to trauma-informed care, really taking a good look at, what are some things we might be doing that might be re-traumatizing? So 5 principles of trauma-informed care. 1, bearing witness to the client's experience of trauma. And I find that, when especially dealing with very, very difficult clients who can sometimes push us beyond what we're comfortable with, it's always coming back to like that core spirit of understanding and empathy. How do I understand this client as a product of trauma, and how do I build kind of empathy for them and understand that what I'm seeing is a trauma response? Helping clients feel that they're in a safe space and recognizing their need for physical and emotional safety. 3, including clients in the healing process and giving them choice and control. One of the big trauma-informed care switches and flips that I've made in multiple settings before, especially in the beginning, was empowering clients, allowing them to have a voice, giving them boundaries with options. So, here are the limits that we can go to based on safety. However, within those limits, you have control, you have a voice, you're empowered. We need to believe in the client's strengths and resilience and incorporate processes that are sensitive to the client's culture, ethnicity, and personal and social identity. So to create a trauma-informed organization and treatment environment, because to be truly trauma-informed goes beyond what we do in interventions with a client. It really goes to the whole system, the whole milieu. So 1 is a safe environment. As I'd mentioned, having with clients, giving them choice, but having a system that appreciates flexibility, collaboration, and choice and minimizes power and control. We want to hire and develop trauma-informed workforce. This is both clinical and non-clinical staff. So it's not just the clinicians, the therapists who need to know about what trauma-informed care is. It's everyone who comes in direct contact with that client in a treatment environment. Obviously, the direct care staff. It could be our medical staff. It could be our housekeeper or our chef. Everybody who has an interaction has an important role in understanding what trauma-informed care looks like. And then leading and communicating about the transformational process. This is especially important when it comes to shifting an organization's culture, changing policies, changing guidelines. It's really important to have good leadership and communication about why. What is the purpose? When I first started doing this back in, 2010 or 2011, it was very difficult to get people on board because some people had the perception that trauma-informed care was letting clients walk all over you, that it was just being nice and doing whatever they wanted and letting them get away with things. So we had to have regular conversations about, what is the spirit of trauma-informed care? How does this go back to neuroscientific understanding of trauma in the brain? What are we trying to achieve? And how do we kind of balance that as an organization? And then, of course, having an ongoing organizational assessment of where are we now, as we do this, where are we a couple weeks from now and in months, and really reevaluating and taking a good, honest look at all aspects of the organization. So building a trauma-informed care workforce, like I like to call it a TIC workforce, it's a fluid, ongoing process with no completion date. I don't know that I've ever worked in an organization where I felt like, oh, we have arrived. We're good. We're trauma-informed. We don't need to work on this anymore. It's constantly assessing, reflecting, evaluating, and say, what are we doing well? What are we maybe missing? How do we get better? So it starts from the top down. It really requires everybody at the leadership level to have buy-in all the way down to the bottom and to be committed to it. Creating the infrastructure means evaluating your policies, your procedures, your day-to-day operations, and looking at all aspects of that. So some of the things I've done in organizations is looked at things like, what are the client expectations and rules? What is our discharge or dismissal policy, our administrative discharge policy? What are some of the things that we do to engage or reinforce participation? And what are the consequences? Do we have consequences? Things like that are what we really look at. Developing an organizational plan and involving key stakeholders, which includes clients. So getting clients to give feedback regularly, having them collaborate with the team. I also find it's really important to find champions of trauma-informed care. So identifying people within your organization at all levels who get the spirit of this, who really buy in, who care about it, and they can be the people who lead and model and champion that transformational process. So again, doesn't have to be your leadership. This can be people in all realms of it who feel really passionate about this. They don't always necessarily have to be the best. They have to be open to feedback and willing to learn. And then what I've done is set recurring meetings and assessment points. So this gives an opportunity for internal evaluation, reflection, goal setting, opportunity to say, again, how are we doing? And really openly, honestly looking at things. So in terms of action steps, again, I had mentioned this before, when people hear trauma-informed care, it's such a vague concept. And I try to get specific about what it actually looks like, but because it's so individualized to the clientele, to the people, to the facility, it can be hard to put concrete examples to that. So it feels very abstract and elusive a lot of times. And I can appreciate how people have a hard time understanding if they're trauma-informed or becoming trauma-informed because it's hard to know what it looks like. But I'll tell you some very specific action steps that you all can do in your organizations to work on that. So one thing, as I'd mentioned with looking at policies and procedures, is go through with a fine-tooth comb all of your rules, for example. It could be the way that you operate, your rules and consequences. If you use a level system, your day-to-day stuff, and look at, are these taking into account that clients are not, being deliberately oppositional or, you know, volitional in this, that what we're looking at really truly is a trauma response. So this is one example with client monitoring, for example. Most every residential facility has a protocol for how often they monitor clients and how they monitor clients. We need to see people, check on them, make sure that they're doing okay, that they're safe, that they're breathing, and that includes overnight as well. There's a big difference between, you know, someone might say, well, we have to see a client, we have to know that they're doing okay and breathing, and at night it's difficult, so we go in with a flashlight and, you know, we just kind of walk in, flashlight, walk out. You have a client who has a history of trauma in the late evening hours. Having footsteps into their door with a flashlight or being startled awake can be really re-traumatizing, and can lead to behaviors that are maybe more of a fight mode, you know, or more aggressive in nature, which then makes us think that they're the problem. So reevaluating, like, how do we maintain sensitivity to the client needs while also being safe and doing things that we know we need to do to keep clients safe. If we're having clients who are in, you know, more of a dissociative or more of a disengaged mode, are we going to be punishing them for non-participation? Do we have different ways to reinforce or encourage a reward rather than focusing on punishment? Another thing is administrative discharges. There are a lot of programs that are quick to discharge clients for the exact behaviors that they're working on, like fixing and adjusting prior to coming into treatment. So it doesn't make a whole lot of sense to kick somebody out of treatment for something that is a manifestation of why they need to be in treatment in the first place. So big caution with that, although of course, you know, we always have to weigh safety for everybody with that, but something to think about. It's really important to view and dialogue about symptoms as normal reactions to abnormal experiences. Seek to understand the function of behavior. This is a really, really important step with working on becoming trauma-informed. Focus on skills to promote the capacity for self-regulation and interpersonal effectiveness. So focus on building prosocial behaviors, working on emotional wellness skills, self-directed attention, self-soothing, and avoid overdiagnosis of antisocial personality disorders or things like, you know, BPD. And then in terms of organizational change, establishing what I call a TIC team. And that is a team that meets either weekly, bi-weekly. If you have to do monthly, that is better than nothing, with the sole focus of looking at how do we become more trauma informed? How are we doing as an organization? And what do we need to do to get there? So it's providing education, support, and training, engaging in clear and open communication with all of the TIC leaders, providing feedback and creative thoughts with, you know, how do we provide trauma-informed practices or start to shift into more trauma-informed practices in our facility. And implementing trauma-informed care programming, supporting changes, which can be very difficult for an organization, and making whatever adjustments are necessary to be successful. So that is most of it. Let me see if I can get to questions. I would love to. Let me stop sharing. I've been ignoring the Q&A. I apologize for that. And let me see about these. So first question, is the effects of trauma memory passed down to children, thus continuing the trauma? So I believe what you're referring to is intergenerational trauma. There are probably a lot of different beliefs about kind of the intergenerational transmission of trauma. I will say my understanding, kind of the simplest form, is that looking at attachment, for example. So if you have a mother who has an extensive history of trauma, it's very likely going to affect ability for attachment or attachment style or ability to really show up. So in that regard, yes, you're going to have intergenerational transmission of trauma in that regard. We also see parents do a lot of modeling in terms of how we manage stress, ability to self-soothe, ability for self-care. So I believe that affects children and grandchildren and so on. Is there a scan to identify defects? I'm assuming that means sort of the brain deficits or the effects of the brain. What I understand is that, especially Dan Siegel, Develop Me Mind, talks a lot about the different brain scans that they do in terms of looking at activated areas of the brain and brains that are less activated. Obviously, we're not going to put all of our clients through brain scans, but they have been able to see kind of different midbrain activation lighting up. Obviously, as I mentioned, cortical modulation and the frontal cortex, where there's either smaller volumes or less activation of that. So yes, clearly they're seeing when they study this and do scans that there's some significant changes in brain. Although I don't know that it would be practical to have our clients routinely doing scans. Let me see a few here too. How do you address family who tend to re-traumatize? In their interactions. That is a difficult one. And this is why a lot of our work, I'll tell you, with Montare Behavioral Health and other agencies I've been with, we strongly believe in a systems approach and doing a lot of family work or conjoint therapy work for the primary purpose that we have people engaging in relationships that have a dynamic that tends to keep people in the same loop, if you know what I mean, like where you have an interpersonal dynamic that is reinforcing the traumatic experience, either invalidating or dismissive or rejecting or just straight up abusive. So a lot of working with clients on recalibrating training is addressing relationships. And a huge part of, so I lean into a lot of DBT in my work. I find DBT to be very, very effective in terms of training, skill building, retraining the brain, things like that. And a big component of DBT is interpersonal communication skills and boundaries. So identifying boundaries in relationships so that we don't have someone stuck in a loop in a relationship where you're not able to make any progress because the trauma continues. Let's see, there's a lot of these. There's a question about, do you support clients with a history of trauma and prenatal alcohol exposure? Have you noticed any difference in the effectiveness of your care or support with them? In my early experience as a clinician, I used to work with children and adolescents who were in the foster care system. So they were taken away from their families and placed in custody of the state because of significant abuse or neglect or both. And many of them had prenatal exposure to drugs and alcohol. I found that with them, we are dealing with a brain that is set and wired in a very different way. And especially alcohol has significant effects on brain development, as well as methamphetamines, amphetamines as well. So it's complicated. You have to look at, I know a big concept with us in that work was looking at what is the capability of our clients, what are their limitations, and what can we expect? And really being careful about having expectations of clients beyond what they were capable of. Meaning if I'm working with a child or an adolescent and they have certain limitations of regulation or cognitive processing limitations, or attentional limitations, that it's very easy to jump to wanting to punish based on poor behavior. And if you recognize limits in terms of their impulse control, or limits in terms of their ability to reflect or be self-aware, or for somebody who has attentional and processing difficulties, maybe they're not able to repeat back to you or summarize what you just told to them. And so they start to look like they're just not paying attention. So a big part of that was just recognizing what are they capable of, and what kind of expectations do I put on them based on that. A good question. How would you do bed checks at night in a trauma-informed way? So one, I try to check in with clients when they come in and ask them about their preference. So, you know, it's not always possible to have different gendered staff, and depending on kind of gender of clients you're working with. But if I'm working with female clients and I have a male client who's working overnight and I know is going to have to check on them, one, I'll address that up front. We have a male staff who's working overnight. Are you okay with that? How do you feel about that? We have to keep you safe. What would be your preference about how they check on you? So are you comfortable with leaving the door open and then they can quietly walk and look and peek in? Or do you prefer to have your door closed and know that they're going to have to open the door and maybe disrupt you? You know, looking at like different strategies, but I include the client in it. And I find that when clients are prepared, they know they have some choice, that it's not as frightening for them. And they can give us some feedback about different things that might work. Okay, I think probably have time for one or two more. Let me see. Where did I get my training in complex trauma? And repeat the names of the books. Yes. Most of my training in trauma came from direct experience. But as I'd mentioned, when I was very new in my development as a therapist, I went through this transformation with an organization on trauma-informed care, and I happened to be living in San Diego in California at the time. And if any of you are familiar with the ACE study that came out of San Diego, it was with Kaiser Permanente. That ACE study was the thing that propelled this trauma-informed care movement in San Diego County and in California, and then spread. So we had a lot of trainers in that situation who trained us on trauma-informed care, but Dan Siegel, very, very big, influential author, teacher on trauma in the brain and how things actually change. So if you want to know the like deep, like nitty gritty, granular, like, you know, heavy brain stuff, Dan Siegel and the Developing Mind is the book that you get and you read. It's a little medically heavy, but you can kind of get to parts where they summarize what the point is. The other really important person, I think, with understanding trauma in the brain and trauma in the body is Bessel van der Kolk. The Body Keeps the Score, one of the best books. I seek out a lot of specific trauma training, trauma work. It wasn't, unfortunately, something that always came to me. I had to look for it. But I can tell you people who are very, very good with trauma in terms of trainers, Peter Levine, Bessel van der Kolk, Dan Siegel. If any of you think of others I'm forgetting, drop it in the comments. And then one more really quick. Oh, guide on some training on mindfulness, art therapy, dance therapy, or other alternative therapies for trauma-focused care. Mindfulness, very, very important part of, as I'd mentioned, kind of recalibrating, rewiring the brain, rebalancing that. Mindfulness can occur in so many different aspects. I'll tell you some of the few that I use in my treatment. Yoga is a big one. Yoga is a mindfulness activity. You are directing your focus and attention on your breath and on like coordinated movements with the body. But yoga is a great, great mindfulness activity. We do mindful walking. We have mindful eating, focusing on sensations, focusing on sensory experiences, focusing on the breath. You can have people focus on music, a piece of music. There's so many ways to do kind of a mindfulness directed attention. And it's hard for clients. So I tend to focus on small periods of time, 5 minutes, 10 minutes, building up maybe 15 minutes. I actually encourage anybody in their personal life to do that as well. And then we do some holistic approaches. Like I should go back and say, so Christy had talked about some of the approaches and interventions we do at Montare Behavioral Health. And there are a few that are very, very focused on the brain. You can tell we're very sort of neuroscience focused. Neurofeedback, great thing for trauma resolution, non-activating, retraining the brain. We do EMDR when people are stable enough, great as well, trauma treatments. We do acupuncture specifically for emotion regulation, or in our addiction treatment programs, managing addiction craving. And what else kind of holistic? I would say those would be the big ones, but I'm running out of time.
We got a TMS.
I got to pass it back off to Renee.
We've added TMS to our treatment protocols as well. I don't know if you mentioned that one.
I did not mention TMS as well, but I'm running out of time, so I'm going to give you the floor back.
Well, this was awesome. Wouldn't we like her to come back and do like the next step in this dance? I think it would be really great. Becca's here, and Christy, are you here? Because this is the fun part. Well, the whole thing was really educational. Thank you. I just feel really blessed that she's our clinical director. So feel free to reach out to me, to Brooke, or to Christy if you have more questions about our work. And if you have any more questions, put them in the chat and I'll be happy to respond to them later. And so now we're going to do a couple of gift card giveaways. Becca, you want to go first?
Absolutely. Okay, so how this is going to work, everybody, is I'm going to ask a question based off of Tiffany's beautiful presentation. Thank you again, Tiffany. And the first who is able to input a response in the chat via chat on your keyboard gets the $50 gift card to Starbucks. Okay, so are you guys ready? Here is my question. What is one of the few things you can do to determine if your facility really is trauma informed? So what's one of the few things that Tiffany talked about that you can do?
Oh, wait.
Okay, all right, we already got some responses.
Yeah, let's see. I think, Tiffany, you're going to have to be the judge on this one. There was, let's see.
I have so many coming in so quick. One of the first ones, checking on the, I'm trying to figure out which one was first.
Well, the TLC or TIC, what is that?
TIC meetings, trauma-informed care meetings, absolutely would be a good place. But I also see a review policy and change from Josie.
All right, so Josie, you're the winner of that one. I'll get you, make sure we get your email over to Becca. And then Christy's going to do another one.
I thought you were doing it, Renee.
Oh, I forgot. I was doing the next one. All right. Can you even see me? My question is a little bit off the beaten cuff, but I want to know who knows what Montare means. It is French, but come on. We named it this. It wasn't just like taken right out the hat for no reason. To mount, yes, but we're not mounting behavioral health. Entire climb, yeah. I'll go with climb with Jody. So Montare means to ascend, to climb, and I know personally that I suffered from some mental health and behavioral issues earlier in my life, and I really feel that I've healed a lot of them, lucky for the track that I've taken. but that it's not a one and done. Anyone who's ever dealt with mental health issues or disorders in your own life or your own family understand that it is a climb. You know, the view from the mountain is really great, but it's a climb, and it requires a lot of checks and balances. So when we stumbled across the word Montare, it just seemed to really be indicative of what we do and why we do it. We help you climb the mountain. So, well, I want to thank you. Tiffany, do you have one last thing to say to everyone before we end this?
I want to thank everyone for participating. To me, what it shows me is that there's people out there who have a genuine interest in looking at how we can transform our care to better suit clients. So thank you all. I encourage you to move forward in that endeavor and absorb and learn anything that you possibly can. And hopefully we can do this again and go more in depth.
And there is one final question. So one of the way you get your CE certificate on CE Go is you go back to that attendee dashboard that we were struggling finding at the beginning. I learned during the middle of this that you have to download your materials before you open the webinar. Luckily, I could find the link and I got you your materials, but there is a copy of the PowerPoint presentation there. And in order to get your CE, all you do is fill out the evaluation form that's there once this ends, and then you will receive your CE by mail. And this is a great platform. So we're really glad you're here, and we plan on continuing these like every other month. And we definitely are going to have Dr. Dzioba back. Thank you all.